All right. Hello and welcome back to what's actually a special episode of Plays Well with Others. We have a special guest with us today, Nathan Miller, and we're going to be taking some of these episodes in 2025 in the coming year in a slightly different direction than what you're used to. We've traditionally kind of dug into this idea of organizational leadership, business leadership, and really focused on work topics. And one of the things that I want to do in 2025 is spread the scope of the guests we have on the show and the topics we broach to focus more on community, more on people's lives and personal well-being in addition to the professional stuff. One thing we do know, and one thing we can agree on, is that businesses are made up of people. So there's business topics that we could talk about till we're blue in the face, but ultimately, if we're not focusing on the people, if we're not admitting that, people are their own individuals, they're unique, they have their own challenges, their own particular thoughts and goals and hopes and dreams, and then there are people like Nathan and Volunteer Behavioral Health that are out there trying to help people. So what we want to do in this coming year is focus more on those people that are helping behind the scenes and trying to provide back into the community that then ultimately supports some of the businesses that we're talking to on a daily basis. So, like I said, we've got Nathan Miller here, who's currently the SVP of Operations at Volunteer Behavioral Health, which is a treatment center or a whole series of mental health service providers that operates here in the Middle Tennessee area, Upper Cumberland, southeastern regions of Tennessee. They currently have 21 outpatient locations, with 3 of those locations having crisis walk-in centers, crisis stabilization centers, and detox services. And kind of what Nathan told me, their primary focus is to serve the underserved Medicaid population and other uninsurable individuals. And the phrase you sent me, Nathan, ages 4 to 94. So it's like you're trying to hit the gamut. So Nathan here has sent me over a dossier of his experience. He's got 28 years of experience in social services and mental health, with 23 of those being at Volunteer Behavioral Health, which is that 10 years impressive. You started as a CTT case manager and then moved into counseling for individual and group services after getting your master's degree. And like I said, now you've moved into the SVP of Operations position that it has oversight of, you said, 11 outpatient locations, operational oversight of crisis and substance use treatment recovery services, including those 3 main hub locations that we mentioned earlier that have the various other specialty services. And you also oversee the state-funded criminal justice liaison program. So you've got a wide visibility and wide range of responsibility at VBHC. So I'm very excited to have you here. I appreciate you sitting down with us and talking through it. So Nathan, you've been here with VBHC for, you said, 23 years, and this is now actually the 30th anniversary in January of 2025 for VBHC. What is it that you have seen happen at VBHC that has kept you there so long? And also, how has that role changed over the years?
Well, and thank you for mentioning, Andrew, about the 30th anniversary. That's a big thing for us. Back in 1995, the merger that we had of the 5 groups, which were Plateau Mental Health, Cumberland Mental Health, the Guidance Center, Johnson Mental Health, and Hiwassee Mental Health, that was a big thing for us. That was the time that TennCare was coming around. That's, they bonded together kind of to take on the new exploits of TennCare and see what was going to happen there and actually provide a better service. You had 5 smaller mental health organizations that came together as one, and we're still here. Some of those providing, those individual locations providing over 60 years worth of service. So we've come a long way, not just the 30 years, that's a big thing for us, but 60 years with some of our individual locations. Over the time that I've been here, I have seen the focus on client care change considerably in many different sections. Most recently, we have went to what we call the THL program, is something the state has put out, Tennessee HealthLink program. And that program is one that kind of bonds the mental health and the physical health together, where our services and volunteer are not only just with mental health now, but we're collaborating with the primary care physicians, we're collaborating with health departments, that these folks are seeing, so that our clients not only have the best mental health that they can have, but the best physical health that they can have too. We have seen, and the state has seen, that people with severe and persistent mental illness usually have a lifespan that is about 15 to 25 years shorter than the average individual. And that's a big thing. So the latest and greatest thing is that THL program through the state that we've been practicing. And we've done a lot of that collaboration with those folks. It means, our care managers are calling the doctor's appointments, making sure the clients are getting there, making sure they've had eye screenings, diabetes screenings, all these different things that they have to have. Children, their wellness exams, just to promote better health in general, which promotes better mental health as a whole. Oftentimes it's a preventative type measure as well.
Yeah, that's really interesting. And that, for the Tennessee HealthLink, is your focus more on the clients that you're seeing first in your facilities and directing them towards the physical health providers, or are you getting intake from the physical health providers as well?
And that's actually going both ways. I'm glad you asked that, because who we have coming in here, as our providers see them in the mental health realm, then, we evaluate for those things. We do a daily living skills assessment. We do several different types of treatment plans as well. And we look at their physical health in addition to their mental health. So if there's a need for someone, say they have diabetes, or they have a heart condition, or they have asthma, or whatever the case may be, if our folks pick up on that, they're going to send them and help them make that referral, and get to that next appointment. As well as we have a lot of partnerships in the community with PCPs and again, health departments, state health departments, that are allowing us to work with them. And when they see problems with folks or concerns, then they will refer them to us, whether that be in an outpatient role or that be in a crisis role.
Yeah, and presumably there's a pretty tight relationship between your patient outcomes. So if you're treating a mental health scenario or mental health issue, and you have a physical health, like you said, diabetes or whatever that is, if you can address both of those in tandem, then obviously you're going to be much better positioned to have that desirable patient outcome, right?
That's correct. We've seen so many success stories since the THL program has come around. When I started, we were talking about 23 years ago. When I started, I don't see it. Those folks that I was seeing back then, those clients that were coming in at that point, they had a lot of unhealthy habits, I guess I'd say, and they're no longer with us. So, now we can see folks that are benefiting from this THL program, and seeing what's happening and the good things that are coming out. And like you said, outcomes are tied to that. There's always revenue tied to that for the state as well, and for insurance companies. So another thing that we've seen, over those years is the movement of services that from long-term, inpatient mental health services, say at a state hospital where someone might live for, months or years, to a more outpatient situation. And that's kind of what we're going to as well. The THL program fits into that. Again, that's community-based, and that's kind of what Volunteer is community-based mental health.
Mm-hmm. Yeah, that's a very interesting approach. I know in my past, I've had conversations with folks that are working in these treatment centers, whether they be independent or state funded, and a lot of what they describe as being the challenge is kind of interacting with those prior authorizations, the value-based care system, and trying to work with these large insurers and payers that don't want to pay for a significant drawn-out inpatient program. So having that outpatient approach, I think, sounds like that's a big benefit to being able to provide care, right?
It is. I think it has given back a lot of people a better quality of life over the years as well. Where they might have been in an institution of some sort for long term, now they have the ability to at least attempt to be on their own or to be more involved in the community. We have a lot of folks that have over the years came from the state hospitals that, are success stories. Are they necessarily as high functioning and as productive as some folks would say? Maybe not, but they're living a better quality of life than they were. And the community mental health centers such as ours and our agency, makes that happen for them, helps them with that by doing individualized treatment plans. So when we have a person come in, a client come in, whether that's new or that's an existing client, we will work with them on their individualized treatment plans, which means what they want to work on. So we meet them, at their needs and their desires at that time. So that is giving the client more of a stake, in their treatment or in their recovery, and they're more likely to work with it. So we've seen a lot of success with that individualized treatment plan, which is, on track with all of our providers. If you receive medication management, therapy, care management, whatever the services are or service you're receiving, those are all tied together. So all of your team, so to speak, sees that treatment plan, and everyone on that works together to make good things happen for the client.
And you just mentioned what you've listed as your core services: medication management, individual and group therapy, and care management. It sounds like what you're doing is kind of trying to formulate a foundation on which you can build the rest of that treatment plan. If somebody's coming in in a crisis, you obviously need to stabilize them. You need to get them to a position where they can then start having those longer term conversations, and maybe that's even inclusive of the physical care as well. Getting them to a primary care provider and getting them on a schedule there as well.
And I'm glad you said that, because I mentioned the crisis piece there. We do offer crisis services at volunteer, whether they're mobile crisis or they're one of our 3 walk-in centers. The mobile crisis covers the larger part of the area that we cover, which, like you said, is Middle Tennessee, Upper Cumberland, and Southeast Tennessee, where we have folks that go out into the ERs, they go out into homes, they go to doctor's offices, things like that, when there's an emergency and someone needs them. So that is an avenue that people can come into our treatment services through. And we do try to get them stabilized first, because if you're not stabilized, then you're not going to be able to work with the therapist or the medication management at that time to build those realistic goals that you need to build.
Yeah, the mobile crisis services, are those like the 72-hour holds, or are those type of wellness type calls?
They can be. Our folks can write the 6404s, which are, involuntary committals, but they can also refer to our CSU units as well, the crisis stabilization units that we have at our 3 major hubs, which are Cookeville, Murfreesboro, and Chattanooga, which is a voluntary stay. So we always try to take the least restrictive approach. So, if that means an outpatient appointment as well, we'll do everything from the outpatient appointment gamut all the way up to the other end of the spectrum, which, if it requires an involuntary committal, we will do that. But we like to try to keep people in the community first if we can.
Yeah, that makes sense. How, I read a lot online about, mental health trends and the United States mental health crisis, especially post-COVID. How has your business changed, or how has your patient base changed since the pandemic?
Well, to start with, during the pandemic, We saw a huge influx of people, huge influx of clients, for a lot of anxiety, a lot of depression. Of course, our whole world was turned upside down. No one was allowed to leave, their home. They had to wear a mask. It was not business as usual. So we saw a huge influx of people. But it also, in its own right, allowed us to see changes in technology that we were able to use. Volunteer as a whole had a really good base. We had dabbled in telehealth for years, because of shortage of providers for years, mental health providers, whether it be psychiatrists, nurse practitioners, counseling, those type of things. And there's still a great shortage on those. But when the pandemic hit, we were able to adjust to that really quickly because of the really excellent IT team that we have. And our CEO said, "Hey, we've got to adjust to this and pivot really quickly." So we were in a really good spot technology-wise to send all of our workers home, and they worked remotely with laptops, with desktops. We did not miss or cancel any appointments during that swap over or that time. We went completely from 90% in-office visits to 100% either video or telephonic mode. We have kind of still have some of that we're using. We never let the pendulum swing all the way back to where it was. We have continued to use increased telehealth services for those in the community. We found through COVID that since we did have that large influx of people, they were in all types of areas. They weren't only in urban areas and, 2 miles from our center, so to speak. They were, 30 miles out in the rural area where they would have to drive. Well, since we serve a lot of the underprivileged and the underserved population, they may not have those resources to get to a center, physically. So we have adopted that telehealth model a little bit more on a larger scale than we had prior to COVID. And we're still using that to a certain extent. So that's with individual appointments such as psychiatry, with medication management. We also use it with the therapy a lot more than we used to. And we also have incorporated some groups into that too, with co-occurring groups, which is substance abuse and mental health, combined. Those folks that are suffering from those or living with those issues, as well as, anxiety and depression groups and peer support groups. So COVID really, in as many ways as it hurt us, and hurt our society, I think it opened the eyes of folks like us to what we could do technology-wise to make things happen so that more people are able to access treatment than ever before, which has the treatment services and the numbers have not really went down that significant since COVID.
Do you see people that say during COVID we had what I call forced adoption? We all went home and you just got to figure it out. You've got to suddenly work on Zoom. You've got to do all of these things, and we didn't have a choice. But now post-pandemic, we have options. Are you seeing more people that were on a telehealth plan come back into facilities, or are you seeing them kind of stay telehealth and then potentially getting more patients because of that capability?
We are. We continue to get more patients that take advantage of the telehealth. We also have probably, I'm gonna say, we were just talking about this a few days ago, somewhere around 65%, maybe 70% of the clients return to the center. That may vary a little, center by center, depending on what kind of area they're in, more urban or rural. But we've had a pretty good percentage of people that actually wanted to return to the building and be seen in person, which that's fine. We welcome that. We want to also, when we offer those telehealth services, we want to also make sure that we offer them the in-person services as well, or telephonic if that's all they have. We want to, again, meet that client where they're at, give them the best option to continue to receive treatment, and that's often decided between the provider that we have and the client themselves. So that's kind of an agreement that they come to. as the best way to be seen.
I wonder too what your experience has been on access. So I know here when we started going remote for grade schools and things of that nature, we had a big problem with people having access to internet and connectivity. And so a lot of the ways that we were approaching that was with these satellite centers. Hey, come upload your homework by parking in this parking lot, and here's the Wi-Fi information. Did you or do you still have those challenges, and how do you approach those when the patient doesn't have internet access or something similar?
Well, each case, of course, is individual, and it's handled differently. I will say that during COVID, we went through a little bit of several different kind of changes. Before we actually, sent everybody home, we had a few people actually in the office, and we would put cell phones outside of the door, in a little box out there that we had, and they were actually able to return to their car and use that cell phone to do their visit to the provider on the inside or their provider at home. We also, in addition to the telehealth equipment that we have and some of the programs that we run, the platforms, we also are able to do some FaceTime, with folks, just individual phones and providers. So that has been a big relief in as much as well, because, most people have a cell phone of some type these days. And like I said, if they can't do the video, if they can't get to us and they can't do the video, then that last resort would be a telephonic visit, which, wouldn't require the video or the Wi-Fi or anything else.
And it's better than nothing, but I gather that's probably the last option, right?
It is, and we use that very limited. That is kind of the exception, not necessarily the rule.
Sure. Well, I think we've covered the kind of the core and the additional services segment pretty well, but you listed a lot of specialty programs here, and you talk about criminal justice liaisons, juvenile justice reform, school-based behavioral health liaisons. You guys are doing a ton that's, at least in my ignorant perspective, maybe out of the box. Can you tell me a little bit about what those programs are and how you're engaging the broader community?
Most of those programs are some of our grant programs, and they are specialty programs. They're grants, either state or federal grants that come through. So one of the governor's big initiatives over the last few years has been to put mental health in all of our schools. While we're not quite there with all of our schools at this point, Volunteer, I believe at this point, has somewhere upwards of 80 positions in schools across the state. And that's not just necessarily in that limited coverage area that we have, of the southeast and middle and upper Cumberland. Those are actually some of them in the western parts of Tennessee as well that we don't officially cover as an agency. That has been a big move. That is really good toward prevention. I'll say that that's one of the programs that I think we have that has the opportunity sometimes to break or end a cycle, of family issues, by working with the children. We all, at an early age and getting them started and on the right track. We also have the RIP program, the Regional Intervention Prevention Program. And that is a program that works with children and their young children and their families. Okay. The Juvenile Justice Reform Program, that is one that goes into the court and receives court referrals for juveniles that are maybe in trouble, whether it be absenteeism from school or minor offenses that they've committed, vandalism, theft, these type of things, at least on a repeat basis, to where they are connected by the judge and the YSO and the court to the child and the family. And that team will send someone into the home. They'll send a therapist. They'll send a care manager versed with peer recovery. So that's actually somebody who has kind of been in that position before, an adult that has worked, with our services before in that family-wise. So, and they'll make sure that not only those things are met and those items that are working with them, but that the outpatient appointments, if they're necessary, are also kept as well. Medication management and those type of things. We also have the criminal justice liaison program. Like you said earlier, I've been in charge of that for the last couple of years. I think I've got 8 of those full time. And what they'll do is they'll work with the court system, and they'll work with the corrections officers and the county jails that they visit, and they will find people who are in need of mental health treatment. And upon their release, they will start setting them up with outpatient services. They'll start seeing them in the jail before the release, and then they'll transition them out into outpatient services or detox services or substance use treatment, recovery, whatever their need is. So in hopes of keeping them from returning to jail.
Right.
So we have got a lot of different programs. Those are just a few. We've got a lot of those type programs that are out there that are just wonderful. I do feel like they're preventative in the long run, because when you look at it, like I said, they're keeping you from returning to jail. They're keeping families from continuing a cycle. And they're also improving the lives of the children and the families that are already having issues.
I think that's an interesting, I don't want to say segue, but I was digging around on your website, and I found one of, I believe it was a core belief. There was a quote that was listed here that says, "We believe that mental illness, addiction, and co-occurring disorders are preventable, and early detection is important." And so as I was reading through and listening to you talk, I was very curious about the prevention aspect. And it sounds like, and I'd love to hear more, but it sounds like the approach is to get these liaisons or these representatives in as many different areas that you can, so that you have that early warning system. You have that ability to interface with somebody as a preventative measure, as opposed to in those crisis situations.
And in addition to the ones that I listed, we also have a newer program that we call behavioral health liaisons, which they are, as you said, it's a community kind of, approach to it, where we're looking for those folks at hospitals, doctors' offices, health departments, anywhere in the community that we can put someone. That's what we're doing with those BHLs. And those are kind of to be proactive, so that things don't get any worse. And we do get those referrals, and those people do get the help they need. I will mention another one that is really good. We've got some grant money from that. We've had that for the last few years, is the co-responder programs, where we have mental health clinicians that are embedded with police departments, sheriff's offices, in the Middle Tennessee area, that ride along with those officers. And, if there's a mental health call, that they respond to it with them. And they, they will either divert, that client to outpatient, when they see them, or that person, individual on the street, they'll either divert them to an outpatient appointment or the CSU, or, again, if the highest level of care is needed, such as a committal, they'll do that. But, again, our goal is to get everybody the help on the outside, in the community first. But the co-responders have been able to divert, hundreds of folks away from an actual hospital stay, just by being there to help. It also helps with law enforcement. It helps with their jobs. Law enforcement these days are seeing tons of mental health calls for various reasons and to various degrees, from someone who might be just, having an argument, they're going through a divorce, they're having some kind of domestic violence thing that, there's some mental health issues involved, to someone who is actually suicidal. So, they're spending more money, they're taking up more space for medications and housing folks in the jail who do not necessarily need to be incarcerated at this point, because they have a mental illness, but sometimes there's no other diversion road for them to go down.
Yeah, that's a fascinating program and topic. I am interested in your experience with these folks that are riding along with law enforcement. Are they getting, call it cross training, or is the law enforcement officer kind of running this scene and saying, hey, I need support from you now, or are they kind of hand in hand? How does that relationship work?
No, usually the officer will take, control of the scene. Our person usually doesn't get out until they know that it's been, it's safe, it's cleared, it's been secured. And then our person gets out. They do wear bulletproof vests, that have been fitted for them. We have found most of our agencies really, really love this, this program that we work with, because it helps them, because they've kind of come to a point where, law enforcement and mental health, while they seem to see the same people a lot of times, their training is very limited in it, so, they're welcoming the help that they're getting, especially here in the Murfreesboro area. That's been a big case with the Murfreesboro Police Department.
Yeah, it's great to hear that of the success stories. You hear a lot about programs like that, and it's not always cast in the best light. But I think 100% it makes sense that you would need that support from a law enforcement standpoint and from a clinical standpoint. You want to have that interaction be, I think you said it, on the outside, because it's probably very unreasonable to try to treat everyone in a inpatient type scenario. And if you can catch that sooner or before you get to that eventuality, much better. So if someone needs access to your services, I know we've talked about a lot of these referral pathways, but if an individual needs access, where would they start?
Well, they would start by calling our centralized access line that is located on our website. That is a Monday through Friday, 8 to 5 central call. And what happens there is when a person calls in, they can be have their case opened with us. They can get an assessment over the phone or by video, usually within an hour or so. That's kind of what we shoot for, to get them with either the medication provider. Well, let me back up. The therapist will come first, which they will tell their story and what's going on and get the presenting problems, all that good information to them first. That will open the case, which will open the gate then for a care manager to speak with them, as well as the med provider, if that's a necessary option, for that person, if that's what they're wanting. Sometimes folks just want to start with therapy, which is great. Everybody is different and will start different places. You can also visit, one of our local locations, which there's 21 of them across the state. They're all listed on our website. You can walk in the front door and say, hey, I'd like to have my case open. I'm having this issue. Can you get me some help? I'd like to get my case open. So that's another way. And then, the crisis option route is another way. You can walk into any of our walk-in centers and get your case open, speak with somebody, and still do the outpatient route. They'll refer you to the outpatient. They'll help you get that appointment. That, again, is one of those BHL jobs, and duties. That's somebody's assigned to those units that will help you do that. Just because you walk into one of our walk-in centers, those are 24/7. There's always somebody there, and they're always open. Just because you walk into one of them and ask for help doesn't necessarily mean you're going to be staying with us. You can get outpatient appointments from that as well. There's also, I will say this, for those people that are looking for just the outpatient services, you may not have to have insurance. I know there's a big thing out there where if you don't have insurance, then you can't be seen, you can't receive treatment. That's not necessarily true. There are some funding routes that can be taken there. So if you're looking for help and you take any of these avenues, you don't have insurance, there's something called Behavioral Health Safety Net, which is a program funded by the state. There's some eligibility requirements you have to meet with that, some financial requirements you have to meet with that. But there's also a lot of grants out there for folks, especially the substance use treatment recovery. Whether that's, you're being seen in outpatient by an individual counselor, or you're in one of our IOP groups, which is the co-occurring group, and those are telehealth and in-person, or you're looking for, our detox services, which are at our 3 main hubs as well with our crisis walk-in centers. And the crisis stabilization unit and the detox centers are usually about a 3 to 5 day stay, 3 to 7 days, sometimes with the detox, depending on the conditions. But there's several ways that, people can get services from us, but just Google the number, Google the website, walk into one of our centers. Any of those methods will work.
And I'll put all of that contact information in the show notes as well. I'm curious on the lack of insurance coverage with all of these grants and with all of the funding. If I were to walk in and say I don't have insurance coverage, but I'm having this issue and I need help, do you have somebody on staff or people on staff that help you work through that, or is that what resources are available to help navigate kind of that landscape?
Well, that depends on which avenue you come in, which door you come in, which is our slogan at Volunteer is no wrong door. So regardless of, and I'm glad you mentioned that statement there, because no matter how you come in, we're going to try to find and get you the help that you need, whether that's with us or without, or, we help you refer to somebody else. But there should be either administrative staff that will help with that, or a care manager, or a BHL, depending on which door you come in or which avenue you take to help you get in with that. There are also sliding fee scales. So, if you don't meet the eligibility requirements, we'll try to work with you, to receive services in one way or another. We don't like turning people away unless there's just an absolute, we have to. We want to make sure everybody gets seen and gets help that wants it.
Yeah, I really appreciate that. I saw the quote on the notes, the no wrong door. I was trying to figure out where that fit in, but that makes a lot of sense. I do appreciate and commend your approach to patient care. It sounds maybe a little trite, but to be able to focus on the same day service model, to be able to turn around an appointment within a couple of hours, to even send everybody home in a pandemic and not miss any appointments it's impressive. It's a very hard challenge to face, and it sounds like you're doing a very good job of approaching it and continuing to move the needle.
Well, it's not been an easy one, and it comes with its pros and cons both. But we still strive to put the client first and their needs, and that's in our book number one.
Yeah, absolutely. So if someone wanted to help you with your mission in some capacity, what can they do? What can the average person do to help what it is that volunteer behavioral health is trying to accomplish?
Well, I'd say one thing kind of jokingly would be, with shortage of staff, go to school, get your degree, come work for us. We need really good people. Sometimes, the shortage of mental health providers is really something big. So we are looking, for good folks that meet the requirements. We're always doing that. There's several different levels of job entries that you can have with us. So that's one thing. I say that jokingly, but I really mean it in the long run, because we are all the time looking for good folks. The other one is, we are a 501c3 agency, private nonprofit, so we do take donations as well. So that's another way of looking at it. And I think the biggest thing, and I know this is going to sound kind of cheesy in some respect, but if you or someone out there that wants to see your community better, wants to help agencies like ours, if you see something with yourself or with a family member or a friend, talk to them, let them know, hey, there's help out there. I want to see you do good. I want to see you live your best life. Here, call this number. Go see these folks. To me, that is the best way, to help a business like ours.
Yeah, absolutely. Which again, the contact information we'll put in the notes in the description and all of that. Nathan, I really appreciate your time. This has been eye-opening. It's been educational, fascinating, all of the things to learn not only the ways that you're approaching mental health, but also how you're continuing to innovate in that treatment space to keep people in the community and to improve the community and to improve not just the patient outcomes, but quality of life and the whole 9 yards. So I really appreciate your time. If there's ever anything as you go down the road, if you need any assistance here in the podcast space, or you want to chat about anything, I'm happy to help. I'd love to keep in contact and keep having these conversations.
Well, I really appreciate you having me. Focusing on volunteer and its mission. I have always been very proud of volunteer. That's one reason I have stayed as long as I have. It is a really good organization with really good goals and a lot of initiative. So, very proud of that. Very proud of the work that they do. That's just who I am, and that's who we are. We're going to strive to continue that. I know I will.
Well, that is great to hear, and I hope that anybody listening that needs care, needs treatment, that is not only if you're in the vicinity of volunteers operations, but wherever you are, if you need that help and support, find the help, whether it be through volunteer or whether it be through any other avenue. The services exist, and what I hope to do, and what I believe Nathan hopes to do as well, is just to continue bringing awareness of those services and what's out there so that folks that need the help can get it. And on that note, again, contact information will be down below in your show notes and your description, but any questions or any conversation, please reach out. And this has been Plays Well with Others. Thanks for listening.